Morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. CR Chandrasekar from Liverpool, United Kingdom. Dr. Chandrasekar completed his orthopedic surgical training at Madras Medical College, and he underwent further orthopedic training in the United Kingdom. Mr. Chandrasekar completed his MCH orthopedics course under Professor Penniman before going on to complete his orthopedic training. After obtaining the required fellowships, he was appointed a full-time orthopedic consultant in Liverpool. And Mr. Chandrasekar has over 50 publications in peer-reviewed journals, including several related to one of his main interests, that is sarcoma. His keen interest in sarcoma also led him to this unique project of his called as Sarcoma Awareness. So today, it's my great honor to introduce you to Dr. CR Chandrasekar from Liverpool, United Kingdom. Over to you, Dr. Chandrasekar.
Hello, hope you can all hear me. Greetings from Liverpool and UK. And thanks to Hitesh for inviting me to give this talk. And it's on Sarcoma Awareness and 10 Commandments. And as orthopedic surgeons, most of us deal with problems involving the limbs, and it is more than likely that you'll come across lumps and bumps, and some of them could turn out to be sarcomas. So my main aim would be to reinforce awareness of sarcomas and what things to do, what you could avoid. At the end of the day, you want to help patients get correct diagnosis and treat them appropriately in a timely fashion. So why am I putting a football for this talk? I think it's useful to know what is the diameter of a football and what is the circumference of a football and how much it weighs. It's a fairly popular sport all over the world. So that is the information to know. And then next we look at various other common things. So just to know how much they roughly measure. So the key thing I want to contrast is something like a golf ball, which is sort of 4.2 centimeters in diameter. And then you look at the football, which is about, say, 22 centimeters in diameter. And if you look at the P, it is fairly small. So this is something to bear in mind throughout the talk. So what I would like to do would be to discuss the resources which you could use to refresh, what I'm going to say, and then have a brief introduction to sarcomas and why it is important to manage sarcomas in an MDT setting, so multidisciplinary team setting. And talk about the extremity soft tissue sarcomas, importance of establishing correct diagnosis. And I'll show you lots and lots of clinical pictures. So the awareness is to be aware of how sarcomas look like, how they're treated. And a brief discussion about, a brief mention about principles of sarcoma surgery, prognosis, and some things which you could avoid when you come across sarcomas. So that, this is a sort of the theme for this evening. And I'm sure most of you are fed up of Zoom meetings. And I'm not sure whether you come across this video recently, a couple of days ago, how democracy works at a grassroots level and the power of the host to mute the Zoom meeting members. So I hope you can put up with the talk today. And if you have time, have a look at this video. It is uh, it is interesting, to say the least. So I think this is a 4-page PDF which we published a few years ago. Just gives you some basic outline of sarcomas. So increasing international sarcoma awareness, if you get a chance, read that to have resources. And also another resource would be to learn about sarcomas. This is mainly for people starting orthopedic training or general surgical training, or even medical students. Anyone could assess this. Just a brief outline of how to deal with lumps, bumps, and sarcomas. Having said that, let's move on to the main topic, which would be sarcomas. The sarcomas, as you know, are cancer or malignancy of the connective tissue. So sarcoma can grow anywhere in the body, in any age group. And the 3 big types, one would be soft tissue sarcomas, which is much more common. And the next common type of sarcoma would be gastrointestinal stromal tumor. And the next least common would be primary bone sarcomas. Sarcoma, such as a word derived from Greek. So it's cancer of flesh, say. And it is relatively rare. 1% of all malignancies could be sarcoma. But when you consider the human body, bulk of the human body is formed by connective tissue, but sarcomas are relatively rare compared to other type of tumors. And soft tissue sarcomas are 6 times more common than bone sarcomas, and about 30 million per the incidence is relatively low. And there are many variants of soft tissue sarcomas, at least 70, but it is increasing due to advances in cytogenetics. And of all the soft tissue sarcomas, the extremity sarcomas form about 60%. And it's also important to manage soft tissue sarcomas in multidisciplinary team settings. So why would sarcoma need a multidisciplinary approach? Because they are uncommon and they are rather difficult to diagnose. And about a fifth to third of the diagnosis by general pathologists may not be correct, or when they're reviewed by specialist pathologists, there is a change in diagnosis. And about, say, 5% of them can be critical in a sense that a benign condition could be diagnosed as malignant, or malignant diagnosed as benign. So it's extremely important to have expert specialist pathologist who's helping with sarcoma diagnosis. And it's also useful to have a good team of radiologists who would help you with the diagnosis, biopsy, etc. And also a multidisciplinary team would have a group of surgeons. So you could have orthopedic surgeon, you could have plastic surgeon, you could have vascular surgeon, thoracic surgeon, retroperitoneal sarcoma surgeon. So there are a number of people who could help with expertise in managing a particular patient. And then often surgery may not be the right thing to do upfront for a number of sarcoma patients. So they might need neoadjuvant chemotherapy, or they would need radiotherapy up front. So these sort of decisions are made in a multidisciplinary team setting. And more importantly, we have specialist nurses and allied healthcare professionals who help with the holistic management of the patient. So we're not treating a condition, so we're treating the holistic needs of a patient. So it's quite useful, and also it is extremely important to manage sarcomas in a multidisciplinary setting whenever possible. I'm aware that not many places have the luxury of having all expertise in one setting, but you could aspire to have such option if it is possible. So I think I work with a group of colleagues and experts, and center have the pathologists. So they are the key to providing the right diagnosis most of the time, along with radiologists and others. So it's quite important to have a good team for management of sarcomas. But you have to remember that benign lumps and bumps are much more common than sarcomas. So things like lipoma, ganglion cyst, fibroma, etc., they're much more common. But it is wrong to presume all lumps are benign. The average size of sarcoma diagnosis in UK is about 10 centimeters. That is compared to 2 centimeters for a breast cancer diagnosis. So it is a fairly large size before people seek attention for the condition. And it's also useful to remember that sarcomas more often spread to lungs compared to your carcinomas, which go to lymph nodes. So to improve the diagnosis, to promote early diagnosis, NICE issued some guidelines in the past which said any soft tissue lump that is larger than 5 centimeter, that is deep to deep fascia, and that is increasing in size, painful, or if it comes back after surgery, that should raise the possibility of sarcoma, and then that should be referred to a specialist center. And in 2015, this guideline was updated, and it was made more generic in a sense. It was they said any unexplained lump. So any unexplained lump, one needs to arrange an urgent ultrasound scan. And then if the scan shows worrying features like increased internal vascularity or indeterminate features, then they should be referred on to a sarcoma specialist team. So ultrasound is a useful screening modality for sarcomas. So if for those of you who haven't seen how a sarcoma could look like in real life, so but many of these are sort of fairly advanced tumors, but we still see them, which we shouldn't be seeing them. So you see number of them presenting after fungation. So it's important to recognize how sarcomas could look like. And because they present as lumps and bumps, so it is quite important to follow a standard, follow good routine too when you're examining patients. This would apply to any orthopedic condition. So like Graham-Appley's look, feel, move, you could add more. So you should get a good history, perform a thorough examination, and have a clinical diagnosis, and then arrange appropriate investigations, and then you try to get to the final diagnosis. And then you plan treatment. An important thing is to accept your limitations and refer on for the benefit of the patient. Just because you can technically do an operation doesn't mean that that is an indication for the operation. So it should be done for the benefit of the patient in the right setting. And if you're treating the patient, review your treatment outcome. And the fundamental thing in medicine is do no harm. So so that's the least you could do to someone who's seeking your help. So try not to do more harm if you. So that is a basic premise, the basic principle of medicine, I suppose. And as I said, sarcoma can occur in any part of the body, and it's also common in children. So 15% of child sarcomas, 15% of all cancers in children could be sarcomas. And look at the red flags. For primary bone sarcomas, bone pain, bony swelling, pain that doesn't respond to painkillers, night pain, and swelling after an injury, so-called injury doesn't resolve. So it should be wary because many bone sarcomas are thought to be sport injuries or muscle tear, hematoma, etc. And for soft tissue sarcomas, we discussed before, any swelling that is bigger than 5 centimeter, increasing in size, deep to fascia, painful or painless, or if it is recurred after previous surgery. So these are the red flag signs you should be aware of. So how do you establish diagnosis? It's a good history taking, and then you should have appropriate imaging, ultrasound, or MRI scan, depending on the situation. And, uh, and an MRI scan is quite useful when you're looking at larger tumors, the tumors that are close to the neurovascular structures. Or you could use alternate scan like a CT scan for people who are averse to MRI scan. And most often you would need a biopsy to confirm tissue diagnosis. And we would advise image guided, appropriately placed core-needle biopsy performed by the treating team. And this would lead us to establishing the diagnosis. And the biopsy, some principles you need to follow if possible. So it should be ideally performed by the treating team under image guidance, obtaining adequate tissue. And that would help the pathologist to come up with the correct diagnosis. So the pathway would be like this. So once the patient is referred, they're seen in outpatient clinic, biopsy arranged, and the pathologist, it takes about a few days to a week for the pathologist to get diagnosis. Sometimes they might need to get some special stains, etc. And once you establish the diagnosis, then you go on to arranging staging scans, because the key difference between a sarcoma or a cancer and a benign swelling is the ability of the malignant tumors to spread elsewhere. And sarcomas mainly spread to the lung. So we would arrange a staging scan of the staging CT scan of chest, abdomen, and pelvis, and we don't routinely use bone scan or PET-CT scan for soft tissue sarcomas. And then you stage the sarcoma. So essentially, if there is any metastatic disease that goes on to stage 4, high-grade tumors largely fall under stage 2 and 3, and low-grade tumors are in stage 1. And once you have the diagnosis and staging, then you go on to planning treatment. And surgery still forms the mainstay of treatment for most sarcomas. Increasingly, we are using neoadjuvant or preoperative radiotherapy for high-grade sarcomas. And also we are using chemotherapy for selective sarcomas, which respond well to chemotherapy. And generally, most patients would receive postoperative radiotherapy. And the idea of postoperative radiotherapy is to reduce the risk of local recurrence. The two main problems with any sarcoma or cancer management is the risk of local recurrence and the risk of metastatic disease. And it's usually the metastatic disease which tends to be critical for survival of the patient. So you want to control the local disease, and you also want to prevent metastatic disease if you can. So the main prognostic factors for sarcoma, the key factor is size. Bigger the tumor, worse the prognosis. And then there are other factors, like if you have a high-grade tumor, the prognosis is not good. If it is a deep tumor, prognosis is not good. And certain sarcomas per se, like rhabdomyosarcoma, clear cell sarcoma, undifferentiated pleomorphic sarcoma, dedifferentiated sarcomas, soft tissue heaving sarcomas, etc. So these diagnoses in itself carry bad prognosis. And older the patient is, then the prognosis is not that good compared to a fit young patient. And then if you have metastatic disease at diagnosis, that dramatically reduces the survival. So the only thing that could be improved of all the of these prognostic factor is size. So if you could diagnose sarcomas early, perhaps there is better chance for cure. This slide shows the incidence of metastatic disease compared to the size of the tumor. So if you have a small tumor at diagnosis, having metastatic disease at diagnosis is relatively low. Compared to when you have a big tumor, there is fairly high chance of finding metastatic disease at diagnosis. And if you have metastatic disease at diagnosis, the median survival is about a year. So this is another way of looking at it. So if you have a small tumor, say less than 5 centimeter, and you would get something like 70 to 80% survival of any all sarcomas. And if you have a large sarcoma diagnosis, and that drops down to roughly about say 30%. And it's said that for every centimeter increase in size of the tumor, there's about 3% worsening of the prognosis. So we'll just look at some of the tumors which we had seen in the past, and large tumors are fairly common. So this was a mixed type of sarcoma. And this man presented with this sarcoma. He was working till he developed a wrist drop. So large tumors are still, and you would wonder why it takes so long for someone to present late. And this man had a large 9-kilogram tumor in his thigh. And he had it for a few years before he presented for treatment. And this lady had a large myxoid liposarcoma involving whole of the thigh. And she initially went to a veterinary physiotherapist who said she's got a muscle tear. And she left this go on linger for 4 years before she sought treatment. It's the same lady, the scans and the post-surgery picture. So this man had a swelling in his ankle for 30 years. And he only came for treatment because it started breaking down. And this man had this swelling in his foot for nearly 20 years. And he used to have a shoe specially made to accommodate for this. I don't know what made him to come for treatment 20 years later, but he did come for treatment. And this lady, who is obvious swelling in the forearm, and this was left for at least 2 years, and once it started fungating, then she came for treatment. So this lady was in a hospital for a few months, and she had what's called an angiosarcoma. And if you can see, she had bilateral lymphedema, which has been chronic. So she had what's called a Stewart-Trees syndrome. But the point was, she was in a hospital for a few months before they could establish diagnosis. This is another lady who thought, the swelling will go down if you apply hot water bottle, but it didn't. It got bigger. And another lady, sadly, they decided not to come for treatment. When they presented, eventually, you could see multiple metastatic disease. So a curative treatment option is gone. And this is not an uncommon problem, pregnant women having back pain. And then people are reluctant to do scans. But this lady had a scan towards the end of pregnancy, and then the radiologist looked at the spine, it looks fine. But they didn't really notice this, which was there. So this was there in January. But then she delivered, and then the back pain got worse, and then she got further scan, which showed a large sarcoma. So you have to be aware of night pain, unresolving pain, look carefully, and sometimes radiologists or even experienced radiologists can overlook problems. Basically, it depends on what request, what the request says. It says back pain, and most people would look for disc problem, etc. But still, it is something that could have been diagnosed early. Whether it would have made any difference, I'm not sure, but one needs to be aware of it. So this man walked into a clinic with a swelling in his forehead few months, and he used to put a hat to cover his head. Another sad story, lady, very active elderly lady, had a swelling in her thigh. This was thought to be a muscle tear to start with. Swelling got bigger, then they thought it was a hematoma, and someone was going to drain the hematoma. But then the anesthetist found a heart murmur and then said, yeah, you need to check the heart murmur problem first. And then that turned out to be a large sarcoma. So awareness could have perhaps called for an early MRI scan and correct diagnosis. This lady had long-standing sciatic sciatica type of pain, and it took a while for them to get an MRI scan. So this man presented with a fungating tumor of his axilla, but it's no fault of his or any of his. The problem was that he had a rapidly growing tumor. So sometimes you get rapidly growing fungating tumor. And thankfully he had a high grade sarcoma, but he is still alive, full hand function. So sometimes you're pleasantly surprised. This person presented with a knee swelling, so it's just behind the knee, popliteal fossa tumor. But by the time he presented, he also had a large tumor in the abdomen. So this is a condition called myxoid liposarcoma, which has got bizarre presentations like metastasis in bones, intra-abdominal mets, etc. It's another sarcoma, just a large one, posterior aspect of the thigh, just as big as a rugby ball. So people still present with large tumors. So someone who has got a history of neurofibromatosis, they can develop what's called a malignant peripheral nerve sheath tumor. And they can reach quite large size. And intra-abdominal and pelvic sarcomas are rather difficult to diagnose early because of the volume in the abdomen and also in the pelvis. So they can grow to big size before it can be diagnosed. And then oftentimes when they are big, then they also have metastatic disease at diagnosis. So another lady who had long-standing problems, doctors didn't diagnose her problem. She went for acupuncture, and then the person said, what's going on here? So this is asymmetrical. So that prompted scan, and she had a sarcoma. And this lady, who is a sort of medical, paramedical professional, who had a swelling in her groin, she left it for a while and went to hospital. They left it for some time before it started fungating. And this turned out to be a sarcoma. And this lady is in her 90s. She's doing well now. And this man had this large tumor uh, of a scrotum, and this turned out to be a dedifferentiated liposarcoma. And he left it for a few years before seeking attention. And that was his tumor. So this man had a large lump on the medial aspect of his thigh, and this turned out to be rhabdomyosarcoma. We rarely use PET scans, but PET scans can pick up metastatic disease because we are quite concerned that this is an aggressive tumor, whether he's got any metastatic disease. So that was the reason he had a PET CT scan. So as I said, late presentations are still common, which is sad, and that's the reason it's quite important to raise sarcoma awareness. We don't want to see football-sized tumors. We want to see tumors smaller, much smaller, preferably the size of a golf ball. So just a few words about principles of sarcoma surgery. So you should have a good recent imaging, and then you should have a good surgical team, ITU, HTU, anesthetic support, nursing, physio, etc. So you need to have a good plan and a good team. And the main priority of any sarcoma surgery is to remove the tumor completely with macroscopic clear margin. So you don't want to see tumor when you're removing it. So you want to remove it with a cuff of normal tissue whenever possible. So that's the main priority. And the next priority would be to preserve as much function as possible. So it is quite important to preserve function for fast, speedy recovery. It is good. So it's good to preserve function, but the priority number one should not be compromised for priority number two. And most of the time, we're able to perform limb salvage surgery, and very rarely we would advise primary amputation. And occasionally we might have to remove the blood vessels, put grafts, or whatever is required. But that's fairly are relatively uncommon, shall we say. So you need to have good position so that you got adequate exposure to do what you want, front and back, adductor compartment, and then femoral vessels, etc. And then you plan your incision, want to excise the biopsy mark, and if you have a large tumor, you want to excise an ellipse of skin. I think you want to minimize the dead space, and you also want to make sure that there isn't any contamination following resection. So you just want to make sure that the tumor is removed completely. And it's not uncommon to have wider margins if the tumor is close to the bone or neurovascular structure. So if you're doing limb preserving surgery, so you want to keep the blood vessels and you want to keep bone integrity if possible for soft tissue sarcomas. So it may be difficult to have a wide margin unless you want to excise the nerve and blood vessels, then which might render your limb quite useless. So it is a fine judgment on how you deal with sarcomas, and it's quite important, especially when you're dealing with large sarcomas. So this again is another large sarcoma of the thigh. So you want to use, if you're using drain, use it distal to the scar, the distal end of the scar. In case if there is any recurrence, if you want to go back in, you can excise the drain track. So you don't want to go proximally or into other uninvolved areas if you can. And you want to reduce the dead space as well. So seroma formation, hematoma formation is a common problem with sarcoma. So you want to minimize the dead space. So for superficial tumors, you can you can excise with adequate margins, preserve function, or do whatever reconstruction that is required. So it's not a problem. And it's quite important to mark the specimen so that the pathologist can orientate the tumor, and then he can give you an accurate idea of the margins, if margins are involved, or how wide the margins are. So this is quite important to have good communication with the pathologist. I think for superficial tumors, you can go as wide as possible on the radial margins and deep margins. So for superficial tumors, it's not a major issue. And sarcomas also occur in abdominal wall, chest wall, etc., and they need appropriate reconstruction. And occasionally sarcomas can arise from the vessels, either vein or artery, and then you might have to do an en-bloc excision and then reconstruct the vessels as required. Buttocectomy is an infrequent situation. So you have tumors involving gluteus maximus, so it could be excised completely with minimal functional loss. So I think losing gluteus maximus is not a big deal. This again is another abdominal wall sarcoma. So this was an extraskeletal leaving sarcoma. So this was the tumor before preoperative chemotherapy or neoadjuvant chemotherapy. And then the tumor shrank nicely following chemotherapy, and then the tumor was excised. So for certain tumors, neoadjuvant chemotherapy is very useful. This elderly man presented with a large fungating sarcoma. And it's a high-grade sarcoma. So this young lady presented with a synovial sarcoma, which was involving whole of thigh medial aspect, medial and posterior aspect of the thigh. So you're wondering how to deal with this. So conventionally, you would go with a medial incision, try to take it off. But then we decided we'll do a thigh split incision, so front and back, and then excise the tumor and then reconstruct, because it was encasing the vessel. So, and it's a high-grade sarcoma. So we had to excise this and then do reconstruction. So this is a front scar and a posterior scar. And she did remarkably well for a period of time following surgery. So the tumor disappeared, but she developed metastatic disease, unfortunately. But you would expect that when you have a large sarcoma. So it's another one who presented with PE and deep vein thrombosis, but you still have to deal with the sarcoma. So in a sense, I think, you plan, you will get the right position, good team, excise ellipse of tissue, skin if required, excise biopsy tract, complete tumor excision. So that's quite important. That's the most important part of sarcoma surgery, complete tumor excision. And then excising the tumor is one part of the operation. So reducing infection, hematoma, deep vein thrombosis, and ensuring back to normality or close to normality are the other priorities. And this was what happened to the gentleman with the large dedifferentiated liposarcoma. So sarcomas, as I said, usually spread to the lungs, rarely to liver and lymph nodes. So you see this X-ray in September, lungs look normal, the X-ray looks normal within 3 months. You see this. And again, so this is the situation. So you can see rapid development of metastatic disease. So you need to be aware of it. So we usually follow sarcoma patients every 3 months up to 2 years, every 6 months up to 5 years, and yearly thereafter. And during each visit, they would get a chest X-ray. They would get a local ultrasound scan or MRI scan or a CT scan of the chest if required. If there is any worry, they would get scaled up imaging. So I discussed this before. So roughly, if you look at 100 sarcoma patients today, about 50 to 55 to 60 would be around in 5 years' time. And the key factor, as I said, is size at presentation, which could make a big difference in survival. And if you have metastatic disease at diagnosis, so the survival, this group is with metastatic disease, and this is without metastatic disease at diagnosis. So if you don't have metastatic disease, you could get 50 to 60% or even more. But if you have metastatic disease, you're looking at less than 20% 5-year survival. Right, so the next part is, what you don't want to do. So, these are the things which you could avoid. Say, don't perform unplanned excision. Say, don't ignore scans. Don't inject sarcoma with steroids. So these are real things. I'm not making this. These are things that are happening or happened. And so don't incise and drain sarcomas thinking that it's an abscess. So don't leave sarcomas, but don't delay referrals. And don't presume all stiff shoulders are frozen shoulders. And to beware of primary bone tumors. Don't use intramedullary nailing if you have a pathological fracture. And obviously, you need to have some skepticism about radiology reports. So patient is in front of you, radiologists are looking at the scan. So you have to marry the scans and whether it corresponds to what the patient is doing. So these are some of things, that there are many situations I could add, you could avoid, but these are some of the situations which I will just illustrate. An unplanned excision is presuming a swelling to be benign and then just taking it out without any investigation or under local anesthetic or using inappropriate incisions, etc. So you need to be aware that lumps could be sarcoma, so you just don't take it out without any investigation. So this man had a cricket ball, a 10 centimeter size lump, and he went to a local hospital. They took it out without any investigation, and it turned out to be a leiomyosarcoma. So this was the scar when he came to us. So you try to avoid such situations. Say, get appropriate imaging, plan, biopsy, or if you don't have the facility, refer to an expert center where they would deal with the problem in a proper way. So we want to give the message to most people who want to learn about sarcomas. And we looked at unplanned excisions and published in 2008, and it showed that 60% of people who had unplanned excision had had residual sarcoma in the scar tissue. So what it means is that when you're doing unplanned excision, then the risk of leaving behind sarcoma tumor cells is relatively high. So you would want to avoid a second operation if possible. If you follow the right pathway, correct investigations, biopsy, etc. So, and also when you're trying to take out the lump, take it out completely. So don't leave half of it behind, and so that someone else need to take it out. So this person had a tumor surrounding the sciatic nerve. So you can see the scar, part of the tumor was taken out, but he was left with this. And then a few weeks later, we had to go back in and take the tumor off the sciatic nerve. So this lady had a swelling in a buttock, and though the radiologist said this doesn't look typical of a abscess, but the surgeon still went ahead and did an incision and drainage, and only to find that the wound never healed. So listen to radiologists if they have concerns. This person had a tumor in his groin, so they thought this is some blocked lymph nodes. Let's block sweat glands. Let's give some steroid injection. So tumor got bigger, and then they excised it, and then part of it was excised, part was left behind. So avoid inappropriate interventions if you can. And sometimes radiologists are pretty, they're very good, but occasionally, you can be caught in a situation where a radiology report says something, and for most, you have once you have a label of a diagnosis, then people don't really think back to see if if it is the right diagnosis. So you need to be aware, and if a patient's symptom is not responding. So this lady had this lesion in her proximal tibia, and this turned out to be low-grade osteosarcoma. So doing a biopsy is something which you won't regret. So this was told by one of my trainers, Professor Grimer. So I think I like his saying that you don't regret by doing a biopsy. So if you're ruling out malignancy by a biopsy, well and good, do it. And then you should be beware of frozen shoulders. So shoulder stiffness not always mean that there is there can be something nasty underneath. So this person had a yaving sarcoma of the scapula. This was thought to be frozen shoulder for a while. So this person had a chondrosarcoma of the coracoid, again was thought to be frozen shoulder for a while. This person had a spindle cell sarcoma of the proximal humerus, and again that was thought to be frozen shoulder for a period of time. So beware of frozen shoulders. If the symptoms are not resolving, X-ray, scan, establish diagnosis. So you need to listen to the patient. So this person was listed for a hip replacement because he came to the clinic. He said, I got hip pain. They got an X-ray. Oh, it looks arthritis. So we list you for a hip replacement. So he came to theater. And then the surgeon saw this, and then he recognized that this doesn't look right. So they sort of bailed out and got a scan, and then this tumor was found. So it's quite important to look at the area where you're operating beforehand so that you could plan properly. And this is another interesting story. Someone who had a knee pain, and he had two MRI scans within 3 months, which showed a large swelling. But the surgeon still went ahead and did an arthroscopy and then found nothing. And then referred saying that, we have investigated the knee pain thoroughly, nothing to find. But then you look at the scans, then there are two scans, not one, two MRI scans which show this. So don't ignore scans. If you order an investigation, follow through. And just because you are a good arthroscopist or a knee surgeon, don't do what you can do, but do what is the right thing for the patient. This again is a very sad story, a very sad story. Young man with knee pain, And he goes to an orthopedic clinic. They do an ultrasound scan, diagnose myositis ossificans. And interestingly, they list him for surgical excision of myositis. So he comes to surgery a few months later, still no X-ray. And then they open this up and then find that, this doesn't look like myositis in this funny. So let's send some histology, tissue for histology. And that turned out to be osteosarcoma. And this person had metastatic disease when he came. So something basic like an X-ray, especially in a young person, or an MRI scan, something which, basic thing, that needs to be done. So beware of sport injuries, knee pain not resolving, thigh pain not resolving in young people. So beware of sarcomas. So I think this is a thing you'd seen before. So she was in a hospital for a few weeks before they decided to refer on. So refer yearly. If you can't treat, refer yearly. Another thing would be, another mistake would be to nail primary bone tumors with pathological fracture. You could see that this is not a simple fracture. So there is some abnormality, possibly, most radiologists would have called it pathological fracture, possible chondrosarcoma. But nevertheless, this patient went on to have a nail which needed to be revised to a much bigger operation. So lytic lesion, solitary lytic lesion, beware of primary bone sarcomas. So the main problems are lack of public and professional awareness. So we still see unplanned excision, inappropriate treatment. And if you go back, I think the fundamental problem is in the undergraduate medical curriculum, there isn't much teaching of sarcoma. So it is rather difficult to get it into the undergraduate curriculum so that people are aware of a condition called sarcoma. And also public also need to take some responsibility. People leave lumps for long enough before turning up for treatment. So a simple message should be lumps can be dangerous, so have it checked. So this was a poster from 1938. So early cancer can be cured. It's true to the day. I don't think, whatever advances that are happening in cancer treatment, there's nothing like picking things up early and dealing with it early. So things for you to remember. So remember the red flags. Remember golf ball. So smaller tumors can be cured. Smaller tumors have got better chance of having curative treatment. And manage sarcomas with MDT expertise for obvious reasons. So early diagnosis is important. So just for you to refresh what I was saying, remember the red flags for bone and soft tissue sarcomas. So and then the 10 commandments for any medical condition, as it were, lumps and bumps, including good history, examination, appropriate investigation, planned treatment, refer if you need to. And if you're treating, make sure that you follow up. So you don't treat and let someone else follow up. So you need to follow up, what you have done is the right thing for the patient. And fundamentally, try not to do further harm. So some of the things which I said you could avoid. And the key points again, they're rare cancers coming from connective tissue, can occur anywhere in the body and any age group. It can present as painful or painless lumps that are increasing in size. And most of them are treatable and about 60% can be cured. So if you get a chance, I can use this module to update your knowledge. And I would end with this. I hope I've not taken too much of your time on Sunday. It's quite important to know that, if you don't know something, you can't see it unless it becomes really obvious. Thank you.
Thank you, Dr. Chandra. What a fantastic lecture. I mean, it really changed my, viewpoint about sarcoma myself, because even I work very closely with the cancer center. And just a few questions.
Sure.
Do you think an amputation may be required in any of these sarcomas, or you think most of the time, if you pick up early, you can go ahead with the limb sparing surgery?
I think I would say majority of the times I would say more. I think in my practice, I would have done about say 4 or 5 primary amputations compared to the number of limb conserving surgeries. So there are a few reasons why you would advise primary amputation. So if you have a really nasty tumor like say epithelioid sarcoma or sarcoma, which is sort of encasing the distal neurovascular structures where uh, limbs conserving surgery is not possible. So it would be extremely, I think it's become relatively uncommon now to perform primary amputation for extremity soft tissue sarcomas. Occasionally you might have to go back in if there is recurrent tumor and there is no option, then you could try, you would advise amputation. There is also an option of using isolated limb perfusion for extremity sarcomas, which may help to keep the limb. So we would discuss that with the patient and also the centers which perform ILP to see whether a patient wants to keep the limb and whether they're suitable to have ILP. So I think I would say a ballpoint figure of say 5 to 10% primary amputations for extremity sarcoma is not unreasonable. You can be quite aggressive and then do amputation for most sarcomas, but that doesn't really translate into survival benefit. So the main emphasis is on limb conserving surgery. And then you also have advances in chemotherapy. So increasingly, we are talking about new adjuvant chemotherapy, which is also helpful.
Thank you, Dr. Chandra, for that. Do you think there are any tumor markers that are available for these soft tissue extremity sarcomas? For example, you have CA19-9 or CEA for the abdominal ones.
We don't really use any tumor markers. I think maybe for Ewing's and osteosarcoma, you get soft tissue osteosarcomas, you get soft tissue Ewing sarcomas, but I can't really tell you on top of my head whether they have positivity of tumor markers, but I don't think we routinely use any tumor markers for soft tissue sarcomas, but there are various things which you could look at, which are prognostic factors like neutrophil lymphocyte ratio, neutrophil platelets. There are various prognostic markers which you could look at, but there isn't any specific diagnostic markers for extremity soft tissue sarcomas.
Thank you for that. And any similar related question is, do you do any genetic analysis? For example, if you have inherited cancer syndromes like Liverpool syndrome, some of these present as a soft tissue sarcoma. And do you think that, rule out any risk for any immediate family member, genetic testing would be required for any of these patients?
Yeah, I think it's an interesting question. So there are, as you point out, so Lefremuni, and then there are a few neurofibromatosis NF1, so they have propensity to have sarcomas. Interestingly, we are part of an international consortium or international research group, which is based in Australia and the guidance of Professor Thomas. So the main aim is to look at inheritability of sarcomas. Because it's such a rare condition, so you need international collaboration to get various centers to participate. And we are one of the centers participating in the Kindred study. So it's called Kindred study, which looks at inheritability of sarcomas. And they've been going on from 2012, and they were aiming to recruit about 5,000 patients, if I'm quoting them correctly. But we're due to see a publication from them soon, and they have analyzed the samples, and they have found some genetic markers in certain sarcomas. So I think it should be published within the next few months. So it's already been submitted for publication. So it is an interesting question, as most patients are also parents as well. So they want to know whether the children would be affected. So it is an important question to answer because of the rarity of the condition. So we don't have an answer at this point in time for all sarcomas. For some, we know it is inheritable, but for some, we don't know.
Thank you, Dr. Chandra. I think that's all the questions that we have. Thank you for the fantastic talk. I mean, it was really, really enlightening, and it really refreshed our minds and made us think, okay, whenever you see a lump, you need to think about sarcoma in the background.
Yeah, thanks very much. I think that the main emphasis of the talk was to make people aware that there's a condition, soft tissue sarcoma exists, and especially for orthopedic surgeons who deal with extremities, they need to be aware of lumps and do the right thing. So appropriate imaging, biopsy, if you can't treat, refer to a center which would give a comprehensive or holistic care. So, and if you diagnose tumors early, then there is a chance of improving survival. So thanks very much for sparing your time on Sunday, and I hope it was useful.